Good evening. I know it has been a long day. Thank you, Rajiv, and the ICH team for the kind invite. I must admit that before I begin this talk, that it's a very unfamiliar topic for me, especially that we don't use much in the clinical setting, especially in the pediatric. And I felt that probably Rajiv doesn't like me, and that's why he deliberately gave me this topic. I did try to negotiate with him to change this topic. I gave up. And then I realized that, everything happens for the good. And I realized that this is an opportunity for me to update myself first. And what I'm going to share is what I learned over the last few days about pharmacogenomics in nephrology. So I'll be quickly going through. It's quite simple because I couldn't understand many of the complexities of the pharmacology and pharmacogenomic aspects. So I'm going to quickly run through these various aspects of pharmacogenomics.
So this is something I really wanted to listen.
So the development and the goal of pharmacogenomics, understanding the common terminologies, it's a little different. I know you are already bombarded with various jargons in the genetic aspect. Now you have to bear with me for some more time with the newer jargons that we use in pharmacogenomics. And summary of the clinical utility, not much in nephrology unfortunately, but I'll try to simulate a case scenario and take you through how it could be potentially useful, and of course understand the limitation and challenges as it exists as of today. So we all know that there's a significant individual variability in drug response. Like we try to give the same dose, and that's irrespective of whether you're in nephrology or any other field. And you often see that it works in some, it does not work in others. There are side effects in some, others do not get side effects, some even with a lesser dose. And we know that the sum of the pharmacokinetics, that is what the body does to the drug, and pharmacodynamics, what the drug does to the body, determine the response and the side effects. And there are various factors in these pharmacokinetics and pharmacodynamics, including absorption, distribution, receptors, the transport proteins, and so on. So when we talk about this individual variability, there are many factors, and one of them are the genomic factors. So you know that these proteins that mediate these various functions are coded by various genes. So variants, which are often single nucleotide variants, can result in disturbing or changing the efficacy of many of these functions, which in turn can result in inter-individual, contribute to that inter-individual variability. And studying this aspect of the drug response, drug side effects in the context of the genetic is termed as pharmacogenetic, where we look at the interaction between the various medications and genes, encoding the receptors, transport proteins, and try to understand how it impacts the drug responsiveness and adverse effects. There are more than 3,500 gene drug variants associations that have been reported, and also the FDA has realized the importance and has taken cognizance of this important aspect of drug-gene interaction, and there are more than 200 medications that have been annotated in their drug product list, where they feel that some actions could be taken in terms of the pharmacogenomics. So when we talk about pharmacogenomics, it's an old concept. When I say old, it's a very old concept because it was way back in 510 BC that Pythagoras first noticed that some individuals develop hemolytic anemia with their given fava beans. From then, when we look at the modern pharmacogenomics, it was initially called as pharmacogenetics. That started in probably early 50s, where it was first noticed that in psychiatric patients who are receiving ECT therapy, they are given the succinylcholine, and because of the difference in the enzyme activity of butyrylcholinesterase, many of them go into prolonged paralysis. So that was the first insight into the interaction between the gene and the drug, and subsequently, most of the attention has focused on monogenic variants that causes a large effect, like G6PD deficiency and so on. And thereafter, with the conclusion of the Human Genome Project, where there is much more information about the human genome came, more faster technology, high throughput technology came, then researchers started looking at a little more broader aspects, looking at multiple genetic variants from many genes that can impact the drug responsiveness and adverse effects. Hence, the term changed from pharmacogenetics to pharmacogenomics. However, in literature you can find that these terms are used interchangeably. And as you can see here, especially in the last 2 decades, there has been a lot of work done in this area of pharmacogenomics, and from 2010 onwards, various guidelines have come up, especially by the Clinical Pharmacogenomics Implementation Consortium. There are many guidelines for various drugs and diseases. So, what is the purpose of pharmacogenomic testing? I can put it into 2 different frameworks. One is something we sometimes do, that is, evaluate the potential benefits of a treatment in the presence of a specific genotype. What Dr. Ashish has said about primary hyperglycemia type 1, where you have a particular variant, glycine 170 to RG, where they are pyridoxine responsive, or a child with SRNS who have a CoQ10 deficiency, where you can give CoQ10 supplementation. But more importantly, what is being looked at is the investigation of the functional genetic variants influencing the pharmacokinetics or the pharmacodynamics. Because typically, this is what we do in a clinic. In our clinic, we give the same dose. If you take steroid first episode of nephrotic, 2 milligram per kg, give it to everyone. Some of them respond, some of them don't. If we talk about tacrolimus, we give it at 0.1 to 0.2 milligram per kg across all, and try to juggle here between the efficacy and side effects. You try to titrate the doses. So it's like some kind of it's like a ramban, we say, one arrow we shoot and we expect that it works in all. But we know that practically, when you look at a bunch of patients, children or adults, this is what it shows here, the number of patients. You can see that many of them do not receive the same dose. In fact, there is a huge variation. Some of them receive a lower dose, some of them receive a higher dose. And you get some kind of a normal curve, which we try to just say that we probably don't know, but yes, this is what we actually do. But what pharmacogenomics try to do is try to achieve some granularity here. Try to understand who are those who are receiving the lower doses, who are those who are receiving the higher doses. So typically, you can see that those who have received lower doses are poor metabolizers, that they don't metabolize the product into an inactive form, whereas those who receive higher doses are those who are rapid or ultra metabolizers, who metabolizes the drug into inactive form. So as you can see, that homogeneous graph now becomes very separate. You can have different curves within that homogeneous graph. So what pharmacogenomics really does is move from this one size fits all, one drug or one dose fits all, to a very personalized, where we are trying to individualize the therapy in terms of dose, the choice of medications. So it has immense potential. For example, you can, in some drugs, you can predict the drug dose, such as with warfarin or with azathioprine, looking at the variants in the enzyme that catabolizes this medication, such as TMT, thiopurines, or CYP2C, C9 in warfarin. It can also help in improving the efficacy by looking at the variants, some enzymes, as in drug of tamoxifen, which is commonly used in breast cancer. It can also predict the activation of the prodrugs, because many of the drugs are metabolized into an active form, such as in clotrimazole. So if you have a particular variant in this enzyme, CYP2C19, some of the variants does not convert it into a prodrug. So what happens is you need a higher dose, it doesn't affect at all. Some of the variants actually metabolizes it faster into a prodrug, so the drug level rises and can potentially lead to side effects. So it helps in deciding whether to use clotrimazole, even if you use it, whether we should use it at a lower dose or a higher dose. And also, it can also predict side effects. For example, using simvastatin, which is again used commonly in hypercholesterolemia, by looking at variant in this particular protein, which is a transport protein, but that pushes the drug from the blood into the hepatocytes. So many of the variants do not allow that to happen in a particular pace. So the drug level rises in the blood and can cause a lot of myopathy. So this is how the pharmacogenomics could potentially help us by deciding on the dose, the type of drug, and also whether it can potentiate any adverse reactions. And you know that adverse reactions are 2 types. A is where it's dose dependent. Higher dose you go, more likely to produce. The other type B is idiosyncratic. It has nothing related to dose. They can develop severe cutaneous reactions, As you can see, if an individual has this particular HLA allele, this is an antiretroviral agent and they can have severe cutaneous reactions. So it also plays an important role in predicting adverse drug reactions. And broadly, it can also extend beyond the routine use in a clinical testing in enabling drug development. And a typical example is in a PCSK9, which is a variant that is the protein variant mutated, and this protein can result in hypercholesterolemia, early onset of cardiovascular disease. Now, and it's a gain of function. So now they have developed inhibitors of that particular protein, such as erythroman, which could be used to bring down the cholesterol. So as you can see here, pharmacogenomics has immense potential in clinical setting as well as in drug discovery. So before I go further into the pharmacogenomics, let's rewind back into some of the basic aspects of genetic, because the terminologies relate to this. This is the central dogma. That is, you have the DNA sequence that is transcribed to the coding part, to mRNA, and its further translation to form what is a protein, which could be an enzyme, which could be a transporter, which could be a receptor. And we know that any defect here or a variant here could affect the downstream. And typically, as you have seen in the morning, these DNA have nucleotides in triplet. That's the codon. And they are constituted by basically 4 nucleotides. All of you must be experts by now after the morning session and the workshop. And you can see here the A and T complements each other, but G and C complements each other. So when we say a mutation, generally we call it, refer it to any variant that causes a disease, which is supposed to be very rare in population. Whereas polymorphisms are single nucleotide variant, which are usually not disease causing, or they cause an effect which is not very large, or which is very not very easily discriminated, like a modifier, or it may make it susceptible. And this is usually present in more than 1% of the population. And usually when we talk of pharmacogenomics, we are usually talking about these kinds of single nucleotide variants which are present in a much larger proportion even in normal individuals. But nevertheless, now we don't use these terms, we use a neutral term called variant. Okay? And then we decide whether it causes a disease or not. So in terms of pharmacogenomics, there are some terminologies that we need to understand. This has already been spoken to in the morning. And allele refers to a single or multiple nucleotides, A, T, C, G, in a particular region of the chromosome. Okay? And you can actually represent it by the actual nucleotide, something like a missense. You know, where you put a notation like this. Where you put a notation, where you put a notation like this, you know, where the change in the nucleotide happens, and here it means that A is replaced by G. Or in pharmacogenomics, because many of the variants may have a similar kind of a variant change. What they do is they give an abstracted representation, and you may have seen this in your literature where they put a star and an allele and give a number, star 1, star 2, star 3, and go on till 17, 15, based on number of alleles they have identified. And these variants can be either homozygous, that is present in both of the chromosomes, or could be heterozygous, present on one of the chromosomes. So for example, this is a polymorphism, okay, which is termed like this. This is a reference sequence number that they give, which is found on the 7th chromosome in the CYP3A5 gene. Can you let me know anyone where you have heard of this gene or an enzyme in the metabolism of tacrolimus? It's a cytochrome P450, part of the enzyme system. So when you have 2 C alleles, you can either rotate it like this, or you can term it as CYP3A5 star 3 star 3. Similarly, if you have 2 T alleles, you nomenclature it as star 1 star 1. And if you have 1 C or T, you can either annotate it like this or mention it as star 1 and star 3. This is how it represents. And we know that when you have this one allele, that is the T allele, is usually has a normal metabolizer, whereas the 3 allele is a faster metabolizer. Okay? And based on the combinations, you can determine whether they are going to be a slow or a fast metabolizer.
So there will be another something like GRCS2. There will be another allele like GRCS2 1 and 3. T is 1, they designated T as 1 and C as 3. So there must be one more.
Yes, there are many. In tachycardia there are things, rare alleles, 2, 5, 6, 7 and all that. There are many alleles. So how they sequence these numbers, I clearly don't understand. I didn't find much information. But there have been missing numbers, like you said. In azathioprine there are 15, then comes 17 and all that. So I don't know how they annotate it.
The frequency in the population that
Yeah,
they have
maybe
found,
that,
and
maybe
it may
that.
change accordingly.
Yeah, it may change accordingly. Now, having known this basics, so as I said, one set of terms is used to describe the allele. So as I said, star 17, star 1, it represents a particular nucleotide and it gives a functional definition. You know, whether it results in an increased function, normal function, or a decreased function or unknown function. After that comes 3 sets of terms, depending on what the protein does. Is it involved in metabolism? Is it involved in transporting, or is it just a susceptibility allele? So if it is a metabolism, involved in metabolism, as you can see highlighted many of the enzymes, it is diploid, usually 2. I mean, it is as opposed to a single. 17 various permutation and combinations, and you have a functional definition what it does to the phenotype. It increases the enzyme activity, or compared to normal, or is there a full functional, or there is no function, and so on. In terms of transporters, they name it as, and you can see that it will be named as rapid metabolizers, normal metabolizer, intermediate, and poor metabolizers based on the allele combinations. In transporters, it is not. It is mentioned as increased function, normal function, or decreased function. In a susceptibility, such as in HLA-B, you have only a positive, and it's a dichotomous. Whether it increases the risk of an adverse or not, it's positive or negative. And you can see here, the metabolic activity obviously correlates with the status of the particular allele. From poor metabolizer, where the metabolic activity is very low, to an ultra rapid metabolizer, where the metabolic activity is very high. So, with this basic, how do we detect these alleles, so-called alleles, which are known to influence the pharmacological response of various medications? You could either do a Sanger sequencing, because if you know the allele, it's a single nucleotide variant. You don't have to screen so many genes. You can do a Sanger sequencing. But many times, many of the drugs are metabolized by various enzymes, may have affinity to various receptors. So you have to look at multiple polymorphisms, single nucleotide variants. So at these situations, you can use a targeted, and this is the most common available commercially, panels for this particular enzyme or for this particular medications. And then in large studies where they were trying to identify the risk factors, they were using the JIVA study where they use SNP arrays, where they look at large number of polymorphic variants. So in literature, I couldn't find much kidney related, and this is some of the gene drug pairs which are relevant to nephrology, mostly in adults, because many of them, which are not directly related to kidney related pharmacology, they are used in adults because of cardiovascular disease, stroke, and so on. You can see here, many of them are listed, and mostly the kidney related are tacrolimus, allopurinol, and azathioprine. And you can see that the genes which are involved, in which there are some actionable results in terms of pharmacogenomics. And I'll come to this a little more. So now people have started looking at its utility in nephrology practice. So one of the most commonly used of this kind of an approach is in the European region, and supposedly the Denmark, Danish, in fact they have their own Danish, pharmacogenomics working group. Basically, they use it much more, especially the geriatric and diabetes population. So they looked at the drugs which can have a potential pharmacogenomic based action in the cohort of CKD patients. There were around 1,200 patients, 1/3 were on dialysis and the rest were not on dialysis. And you can see that, like in pediatric or adult, polypharmacy is quite common. There are at least 3, maybe 10 medications, as you can see here. And of this, you can see nearly 1/3, 30% of them had pharmacogenomic impact. That is, if you had a pharmacogenomic information, you could either modulate the dose or change the medications. And you can see that the most combinations of 2-drug combination or 3-drug combination were these, which invariably involved an antihypertensive like metoprolol, H2 inhibitor, pantoprazole, and then cholesterol for hypercholesterolemia. So these are the common combinations that had a significant, potentially significant impact if a pharmacogenomics is done. So, and more recently, the Indiana group looked at the utility of pharmacogenomic predictors in the antihypertensive response. So they screened for 40 variants in 12 genes in their population of 300 and odd patients with hypertension, and they found relevant drug-gene interactions to be higher in those who are uncontrolled hypertension versus those who are controlled hypertension, indicating that probably using this information and titrating the doses or switching medications may have been useful to bring these patients who are uncontrolled hypertension into the controlled group. Similarly, there are other trials that are happening in various countries such as GARD, US, and so on. But I'm not getting into the details, but just telling you that this is coming into the nephrology practice. Now let's see how to use this with existing information. I have two case scenarios for pediatric. Didn't do any pharmacogenomic, but I'm assuming that suppose I would have done, how would it have helped? So this is a 6-year-old young child, ESKD, syndromic, secondary to ciliopathy, received a kidney transplant probably 1 year back, was started on the routine dose of tacrolimus, and as you can see here, the levels always remain low, less than 2, even despite increasing the tacrolimus dose. And generally they say don't go beyond 0.3 milligram per kg. So at that point, we used an enzyme inhibitor, fluconazole, and we can see that the levels of tacrolimus came up because it inhibited the metabolism of tacrolimus. But could there have been another way to resolve this using a pharmacogenomic approach? Second was a child who was an adolescent, weighing 50 kg, ESKD secondary to neurogenic bladder, received a kidney transplant, again starting on a similar dose. So you can see here, on 0.1 milligram per kg, you can see the levels, despite decreasing the dose of tacrolimus, levels were high. So as you can see, two contrasting situations using a similar dose of tacrolimus. So how can pharmacogenomic resolve this, and what do we do next? So clearly here, the interest here is in the metabolizer chief, that is a CYP3A5. Which actually converts where the tacrolimus undergoes an oxidative metabolism. So when you want to decide whether to use a pharmacogenomics, there are a couple of factors that you need to look into. One is the drug factor. That is, does it have a narrow therapeutic index? Because that becomes very important. A little exceeding higher can result in toxicity. Lower, it cannot have the effect. Is the drug prodrug or active drug, like a clopidogrel, losartan? Losartan is actually a prodrug. It has to be converted into an active drug. And also, what does the variant do? Does it decrease the efficacy or increases the toxicity? We need to have some basic information about the medication that we are trying to investigate. Second is the clinical factors. Like, is there any other factor that's increasing or decreasing the level? For example, using rifampicin or an anti-epileptic or using an antifungal. All this, or patient having even a diarrhea, the tacrolimus level can go up. So we need to make sure that there are no other factors that are causing this change, fluctuation in the level. And also, okay, we know that there are genetic aspects in this, but what is the strength of evidence? Is there clear evidence that we can identify variants that decreases the metabolism or increases the metabolism and so on? So we have to do some literature review for the quality of evidence and whether testing is available for those particular variants. And also very important, these variants that can cause rapid metabolizing or slow metabolizing, the frequency of these variants can vary with populations. So we need to also understand, is the variant likely to be relevant in the population that we are looking. So some variants are common in African, some in Indian, some in Caucasian population. So all this goes, all these factors we need to keep in mind while addressing the pharmacogenomics. Okay, we find that there is some evidence that if we investigate, look at the CYP3A5 allele and all, we may find something. Where do we go next? So I'm listing two websites where it will help you to know whether it is worth going for a pharmacogenomic testing. In this case, tacrolimus. One is the Pharma knowledge base that has clinical guide annotations, including in pediatric pharmacogenomics. There are more than 200, close to 300 variant drug combinations, 50% of them are associated with drug toxicity, and the rest either with efficacy, drug metabolism, or combination of these mechanisms. And of these, 106 combinations are of interest in pediatric care setting. The other side is the Clinical Pharmacogenomics Implementation Consortium, started in 2009. I'll take 5 minutes, where there are given guidelines for 110 gene drug pairs. But this is mainly focusing on the cytochrome enzyme system. But what they have also done is come up with clinical guidelines to give you clear instructions what to do when you get a particular variant, which are endorsed by various societies, depending on the drug, warfarin, or is it a statin, and so on. So here I queried, because I don't know much whether it's be useful, I queried here, I put the word tacrolimus. So this is what it gave me. So it gave me that there is a guideline available for tacrolimus and CYP3A5. And I go into this and this came in 2015. So it's a decade back, but still we have not used it in clinical. So it shows that there are barriers to its use. And it has been recently updated somewhere in 2020. And as you can see here, this is one. Because as you can see here, it is also the same enzyme is involved in other drugs, especially the statins. But if you can see, the level of evidence is A. That means it's quite actionable. When you say level C, it means that it is not much actionable, but this enzyme has been found to be quite important in some other medication. So here is tacrolimus. So they given a level C evidence for this. So since it is A, it was worth looking towards it. So I put this gene name in the search box, and this is what, and the guidelines, and this is what it showed. It showed that I should look for particular alleles, 1, 3, 6, 7. These are the alleles I should look for. So when I ask for a testing now to the company, I should ensure that these alleles are definitely covered. Otherwise, you may get a misleading result. And it has also given what the likely phenotype will be if you have this allele. So if you remember the first case, so if you can see, star 1 is an extensive metabolizer. So what happens? You need to give the drug more and more. Whereas star 3, 3, 6, 6, 7, 7, or a combination of 3 and 6 are poor metabolizers. That means they are not metabolized into inactive form, so you need the dose at much lower level for a normal level. So it gives you some kind of a phenotypic information about this. So probably the first case was belonging to this group, because as you can see, we needed a lot of level. And what does it mean? And then it gives you a dosing recommendation based on the variant that you have identified in your patient. So as you can see, if I find star 1, it states clearly that you start at 2 times the dose or 1.5 times straight away. What we did was, we were very cautious, we did 0.1, then 0.15, 2, like that. So here it's very clear that you can directly start at 0.15 to 0.2, you can go up to 0.3 milligram per kg per day. And the classification recommendation is very strong. So there's lot of evidence available here. The second patient probably had which phenotype? Can anyone guess which genotype? Where despite a small dose, the levels were very high. So probably it had one of these. So let's assume a star 3, that is, it was a poor metabolizer. And you can see the recommendation for a poor metabolizer is you initiate the therapy with standard recommendation, and then you start coming down. So, but at least you have an understanding that this patient is likely to have a high level with a conventional dose. So, it gives you a lot of information before you start prescribing the medications. So, there is not much literature in Indian setting how we use this actually in a real world scenario. This is one of the recent data from AIMS published this year, where they looked at in 160 patients on CYP3A5, but I couldn't much decipher or conclude from this, because they really gave non-standardized terminology like wild type, heterozygous, homozygous to describe the various alleles rather than standard terminology. Hence, it becomes very important to update ourselves about standard terms that are used.
So they must have used only one variant.
We do not know.
It's the one variant.
Yeah, but we don't know which of the variants we have studied. That is why. So in methodology they have mentioned that CYP3 position. So we don't know whether it's 1, 3, 6, 7. We do not know. So, but anyway, they identified that the fast metabolizers had lower initial tacrolimus, something what is known. Similarly, there's another way to look at this. You can use the Pharmacogenomics website. And for example, I was interested in looking at azathioprine before you dose. And what they're given is that there is an actionable pharmacogenomic variant in the protein TMPT and NUDT 15. So there are intermediate metabolizers and co-metabolizers. So when I test for the allele, and they also give a list of alleles that needs to be screened. When I test, and if I find a particular allele or a variant in the patient, I can input it here. It's a drop-down box, and that is what I have done here. I gave a simulation that I found allele star 2 in the NUDT, and I found a star 17 TMPT. Now it gives you a recommendation. So as you can see here, it gave a recommendation that this genotype suggests a co-metabolizer, whereas nothing much can be commented on TMP. And it shows that the implication is that it greatly increases the risk of thiazide-induced leukopenia, neutropenia, and myelosuppression. So clearly here, I will be a little careful about the dosing, probably start at lower than what is recommended, and or closely monitor for the side effects. And they have also given by how much you have to reduce. They have said that somewhere around 30 to 80% you can come down of the expected dose. So this is how pre-priori we can, by predictive pharmacogenomic testing, decide whether a particular medication has to be used and what dose it should be used. But easier said than done. I mean, we don't obviously use it, suggesting that there are a lot of challenges and limits, especially with related to testing and informatics, because it's an evolving field. More and more number of variants are being identified. More and more medications. Unfortunately, not much in the field of nephrology. And also, as nephrologists, we'll be always confused or conflated by the drug level changes as the GFR worsens versus the pharmacogenomic recommendations. Because we know that we do a lot of GFR based corrections for many of the doses. What do we do in that setting? So when they say if you have this allele phenotype, GFR is 50, we have a particular dose. And they say that for this variant, you have to reduce the dose by 30%. Is it 30% from the original or from the GFR correction? So these are the practical challenges that we find. And also our lack of awareness, how to use this, our perception that it's not clinically useful, the feasibility, accessibility and availability of the test, and the cost. For example, the testing for the tacrolimus alleles costs around 11,000. For the azathioprine, TNT and the NUDT, both of them cost around 18,000. But it's a one-time expense. It's not that something you need to repeat. But you could be in a carefully chosen population. It could be potentially helpful. And of course, the ethics and legal issues, especially when you're using these variant data, something similar to your, your clinical genomics. Those issues also apply. So as you can see, it has a potential, especially in the nephrology field. And I think we are far lag behind in oncology, psychiatry, diabetes. They have been increasingly using this pharmacogenomic approach to individualize therapy. So in summary, pharmacogenomic no doubt is a tool for clinicians to provide a precision pharmacotherapy. But the role currently in nephrology is being limited, but is increasingly being evaluated, as I've shown in some of the studies. And to use it successfully in a clinical setting requires that we as clinicians are familiar with how to access and use these pharmacogenomic resources. Thank you.